I want to introduce Veronique Bosca, Dr. Veronique Bosca. Veronique, let me get her proper title, is the CIHR Schlegel Industrial Research Chair for Colleges in Seniors Care. She's also the Executive Health Dean at Conestoga College. And if anyone's ever had a chance to visit that, they have the most incredible nursing training program. They have a whole building that's set up as a simulated hospital. And they're doing very, very innovative nursing care. And I want to bring Veronique into the picture because during this pandemic, it exposed some real horror stories in long-term care. And we have so far talked mostly about acute care, but we're actually going to have to pump a lot of money into long-term care. I've heard estimates of an increase of 40 billion in funding across Canada in long-term care. And there are other estimates that go up into the 70s by the time we get to 2050. And I want to ask Veronique whether the answer is just to pump more money in and increase beds and staffing, or is that just not going to solve the problem? Veronique.
Thank you, Jeff. I think we all agree there is a lot more to be learned about COVID-19 and how it created such havoc in our nursing homes. But I stand behind some core principles that really should guide the efforts to improve safety and quality for life of seniors in Canada, not just those living in long-term care. And so, of course, the residents and the staff working in our Canadian nursing homes had a really, really tough time and still do have a tough time. And I've seen many a story unfold that did not end well during the pandemic, but it's not over. However, pushing all that money into long-term care is also not going to solve the problem. We do need to create a better future for older Canadians who need care and their care partners, and we need to be able to value and listen to them. And so I think at the heart of these discussions lies what is the value that we have for older people and who are we going to pay to care for them, because we cannot put it all down on the care partners, the families, the spouses and the adult children who often live on the other side of the country. But Jeff, to come back to your question, no, it will not be sufficient. At the end of the day, we need investments in aging at home, because there is simply not enough money in the world to build long-term care beds and staff them for every person who will develop a dementia or who will require help with their ADLs. And so we really need to focus our efforts on prevention, on keeping people mobilized, keeping them engaged and in our communities. We need to invest in our daycare programs. We need to invest in high school learning around what is it that you can do to help older people in our community. And then, of course, we need to invest in home support services. When all of that is said and done, then yes, we need to look at long-term care services, but we cannot build the long-term care homes that we need for every older person needing care. And I agree with our existing long-term care homes. We're in a bad place. I think spending more money on doing things like we've done them up until now is not going to solve anything. I don't need to explain to this audience or to these panel members here is that things are really, really tough in long-term care, despite the best of intentions and very hardworking people and families and residents who believe that things can go better. It's been very difficult. I can tell you that in the last year that I've never worked with a fully staffed team, which means I'm going to have to set some priorities, which means some people will not receive the care that they need to receive. And as a result, things will not be as quality or focused on quality of life and well-being as they should be. But then you look at long-term cares are kind of hospitals in a little bit of a different version. However, the difference is that you have 1 or 2 charge nurses for 200 very complex residents, and then a very large group of dedicated yet unregulated care providers who we know have a retention of about 40 to 50%, and charge nurses are the same. So every day you come to your work, you work with new people that do not know the residents, that don't know the care system, and people are burned out. They cannot seen in the last year, then we probably have taken out another 20% of staff that was dedicated to long-term care that are interested in gerontology. And then adding to what we've seen in the last 3 weeks with these protests coming around, and people just realizing that maybe caregiving is not what I want to do. So in reflecting on some of the shifts that I've done, and you drive home early in the morning or late at night when you do a double shift, I like to think of what is it that I can do better tomorrow? And so when we look at long-term care, and I'm not taking away from the investments that need to be made in the community, but when you look at long-term care, there is so much we can do to do better. For one, we can invest in staffing. Right now in Canada, we provide about 2.1 hours of care to a resident in a long-term care setting. Across the world, there is a minimum of 4 hours of care. And so we just do not have the staff to provide the care that is needed at a basic level. We are not talking about quality care or person-centered care, just the basic care. So in order to do that, we have these complicated systems and tracking records and utilization codes, and to get it all figured out to see how much money a long-term care home can get from the government. But it really doesn't matter how much money and time I put in those utilization codes and that tracking, because I think it was previously said by one of the other speakers, is there is a ceiling to the funding envelopes. And so if I say this is the level of care that is required, the answer I will get back is, well, there is only funding for 1 nurse per 200 residents. There's only funding of 8 PSWs per 60 residents. That's all you get. So you're going to have to work with that. So it's very easy to drop the quality of care to basic care. And then if there is a pandemic or a shortage, that basic care drops even further and lower. And so staffing there is no secret in quality care. It's called decent staffing that is well trained and well prepared. So they don't have to work short, they don't have to do overtime, and they actually get valued for the work that they do. There is no one, I think, in this audience or in this panel that can provide care in 10 seconds, looking at an assessment, not being able to write down your assessment and say, we're just going to cross fingers and hope for the best, because it doesn't work like that. And so staffing would be a very important element of changing long-term care. Another element that I would like to propose is that integration between the community, between acute care sectors and long-term care is a must. And that is not in place right now. I would not be the first long-term care nurse that sends somebody after a fall to the hospital because they complain about pain in their shoulder, they have limited movement, and there is swelling and bruising noticeable on the shoulder or around the clavicula. And that resident comes back 4 hours later with a prescription of antibiotics for a UTI. Nobody looked at the shoulder. And so I've been on the other side. I've worked in the emergency department as well, and I can see how it happens. But that's not okay. We cannot do that with our seniors in Canada. During the pandemic, one of my dogs got sick very suddenly. I brought him to the emergency vet Saturday night at 1 o'clock in the morning after my shift. The emergency vet did an x-ray right there and then. In long-term care, I have to wait 24 hours for that, not on the weekend. The emergency vet said things are not good. There is a great tumor in there. You want to look at pain medication right now or surgery. Surgery is going to cost you a lot of money. This dog is quite a bit older and has some other underlying conditions. This is not a good idea. We think you need to make a decision. I made a decision. I said to the vet, I would love to have my family here with me to say goodbye to this dog. Is this possible? The vet said, yes, just wear your masks, bring everybody in. I'll give you all the time you need. And we sat there for 2 hours with our dog until we were ready to let him go. How does it feel as a nurse to tell family members over and over again, you can't come in. I know your mom is dying. We can put the iPad up, but you cannot come in. So what kind of country and what kind of values do we uphold if our pets get better care than our elders in long-term care? The fact that I have to fax orders to a pharmacy in 2021 means that there's been no attention, no technology investment, and no clear desire to make long-term care better. And that's very, very difficult, I think, to accept. COVID has hopefully uncovered some of that, but we have a lot of work to do.
You know, Veronique, I don't think people realize, most people, I mean, let me ask you a personal question. How often do you have a shower? You froze.
I don't double shift every other day. But if you're in long-term care, Jeff, that's right. Once a week, if all goes well.
Look, imagine
Yeah.
if you go into a nursing home in Canada and you are possibly not only urinary incontinent, but fecally incontinent, you get one shower a week.
If there is no outbreak.
If there is no outbreak. If there's an outbreak, you probably don't get that. And I remember when you were on duty at Christmas, you told me a story where you had to see 196 patients during your shift, and you had to change your PPE before every patient to make a full assessment and change it every time you came out in the corridor. Is that right?
Correct.
Okay, let's move on and back to Dr. Jewett. Again, during the pandemic, we got used to virtual meetings using Zoom, etc. Yet most of us can't even phone or email our doctor. We must make an appointment, travel to a clinic, wait for a typically delayed appointment. Can we fix this? I mean, this seems elementary.
I couldn't agree more on this. And a number of years ago, and it's Wayne, you'd remember this, is 10 years ago or so, the Ministry of Health invested in a telehealth program to allow patients to go to a local clinic or a designated place where there was a setup that they could have an appointment remotely with the consultant in Toronto or wherever. The adoption was very low. And the adoption was low because the physicians found this to be very structured and to be not only a new innovation, but also interfered, or at least the perception was that it interfered with the flow of the clinics. I was one of the early adopters of this because much of the follow-up in cancer care is establishing that people are well, and it isn't necessary to review tests in person necessarily. You can identify people, obviously, who need to come in person, but there is a huge burden of care in cancer care that is follow-up visits, establishing people are well, basically. And this was about the same time, and again, Wayne will remember this, when the hospital felt we should put our email addresses on our business cards. There was a lot of controversy about this. In fact, patients were very respectful and didn't bother their clinicians unless they had a genuine reason. By and large, there were the few that were different. But the flip side was people traveling could get some advice. They could be directed to emergency care in other countries, to colleagues, and get things attended to for their peace of mind, or in fact, to plan their return to Canada. To this day, American physicians are advised by their lawyers not to use email to communicate with their patients. And many of our clinicians also are resistant to using it. So these are examples of barriers to improving communications that were basically turned on their head by the pandemic, and the bulk of care was being provided remotely, more effectively by some than others. But I think patients have really recognized how effective this can be and are going to demand that we do more of this, and that virtual clinics will become really the order of the day. So I think this is a great example of disruption forced upon us by public health means, which we should have really been adopting before. So where is the fault on that? I think it's multifactorial, source dependent, but I think we have a lot to gain here through using current technologies.
Thank you. Um, I, I don't know how much time it takes to find the phone number for a physician, but often I think it would be really helpful. And that's for me finding it with all my connections and resources. I'm trying to imagine someone with English as a second language in a rural community or in a northern community trying to make contact, why they can't send an iPad photo of their mole, or why they can't do something rather than catch a plane, even for God's sake, down to Winnipeg or Yellowknife or somewhere, is incredible in this day and age. And the idea of having to use fax machines for pharmacies is unbelievable.
I don't know if I can interject here.
Please
Well,
do.
I'm
Yeah, in the north, the first time I had my experience with the computer screen and the thing from someone up in Cambridge Bay, which is a long way from Yellowknife, which is a very expensive flight. Examined a postoperative patient. I was nervous. I wasn't sure whether I liked it or not. Things went amazingly well. The X-ray was put up. I examined the patient. I talked to them, and then my feelings immediately reversed from I'm a little bit uncomfortable with this situation to what, why the HE double hockey stick am I not doing this more? You know, like this is something that, where the patient gets, I think, very good care. They're not having to take basically 3 days out of their life, 1 day to fly down, 1 day to be there for their appointment, 1 day to fly back, and getting excellent care. The nurse that was there with the patient was a rock star. So, you know, all my questions were answered, all the patient's questions were answered. In a lot of ways, I think that was a better visit than my average visit.
Okay, Josh, I want to come on to the next question for you. One that is dear to my heart. Many of us work in big hospitals, and we've all got stories about how incredibly bureaucratic they seem, and it seems that the statistics bear out that our public hospitals are not particularly efficient. The administrative overhead seems quite large, and yet, as you and others have talked about, surgical time is actually severely limited. And if one were to invest in starting a car factory, and then build this big factory and only operate it essentially for a limited shift per day, you'd be out of business. I mean, it just wouldn't work. So we've got this great big waiting list particularly for orthopedic procedures, and yet we've got orthopedic surgeons who are unemployed. I mean, I think 16% or something are unemployed at the moment, and others who are underemployed, and others who are farming half their time.
Ouch.
Could we use our capital and staff more efficiently? Do you have some honest comments about this?
Oh yeah, absolutely. I mean, you're kind of hitting at the heart of the object, heart of the problem. I know Wayne has can fill in here too with lots of experiences. The MRI story made me want to pull my hair out. The idea being, we have, Canadians waiting, they're suffering, and it doesn't necessarily mean they need surgery, but they need to at least see an orthopedic surgeon to get an opinion. We have orthopedic surgeons who are unemployed, and the bottleneck is getting into a group that is able to split OR and clinic time, right? In the province where I was in New Brunswick, billing numbers were traditionally limited. So if you wanted to bring on a new orthopedic surgeon, you'd have to make a very detailed case for why this person was needed. They would do an impact analysis, so figure out what this orthopedic surgeon would need. For me, when I went to New Brunswick, they had to essentially lie and say that as a trauma surgeon, a foot and ankle guy, I needed no additional equipment. I could do a lot of my stuff outside of the OR. I didn't really need that much OR time, just to basically make these administrators, of which there's more than surgeons, make the decision to allow me to come into the province to provide care. At that point, I was the one of two foot and ankle surgeons for the whole province, and then rapidly became the only one that was there. And despite this lack of services, the orthopedic group had to go through all these hoops in order to bring me in. Once I was there, getting access to clinic time and OR time was quite a struggle. So I think what we're seeing is that the physical space that's required, the infrastructure for an operating room, an orthopedic clinic, all these things have become a big bottleneck for people getting access to orthopedic services. And as you know, Jeff, I spent the last 7 years of my career with my students studying how to get foot and ankle surgery done outside of the OR without the use of an anesthetist, to try to bring down the costs of care to get patients access to desperately needed foot and ankle care, operative foot and ankle care, without having to use up resources, so that my partners doing hip and knee surgery, who had wait times of over 2 years, weren't having to have their list grow in order so that my list of foot and ankle problems could be dealt with. You know what I mean? So any gains I made in getting more OR time meant someone wasn't getting their necessary hip and knee surgery. So trying to find ways to open up opportunities for foot and ankle patients without coming at the cost of others. But it shows you how severe the bottleneck has become, where now we're kind of rearranging deck chairs on the Titanic to try to figure out, well, who needs their surgery the most, rather than being truly patient-centered and saying, just who needs to see an orthopedic surgeon, who needs to have an operation done. Let's figure out a way to make that happen in an efficient manner.
Surely we should be cutting back on our administrative overhead, and we should be operating 2 shifts of surgery, shouldn't we? Shouldn't the emphasis be on getting more OR time to maximize the throughput and the cost per patient, and reducing the cost of patients who are at home not working, ending up in nursing homes and things? Shouldn't we be using these hospitals and the operating time more?
I mean, the obvious answer is yes. When you're looking at doing things more efficiently, obviously, the more efficiently you can have something done, the more you can do. For me, as a foot and ankle trauma guy, it was particularly heartbreaking, because on both sides, I would see patients with broken bones who always got the care. Once I fixed their broken bones and they wind up with a complication, or doing a revision surgery when things didn't go well, most patients were working age, under 50. And I can speak to many instances. I can think of 4 just right off the top of my head, where people either went into bankruptcy protection or lost their home because they had a badly broken ankle or talus or calcaneus, and were not particularly well educated. These are laborers, and lost the ability to work, and then wound up on my wait list to get their surgery, and had to wait 18 months for their operation, then had to have a 12-month recovery from their surgery. Things fall apart in the interim. Anything we can do to prevent that from happening, anything we can do to make that work is inevitably, I mean, it's a good thing. And I don't know, there's lots of very experienced people on this panel, particularly Dr. Marshall might want to help me here, but where I've only been in practice for 11 years now, but it seems like administration keeps growing, and the number of people telling me what I can and can't do seems to always be growing. So I can't speak to that too much. I don't have much experience with it, but we need to get people through.
Wayne, do you have a comment to add?
Yeah, I do. I mean, I could, spend the next 2 hours giving you anecdotes of all the ridiculous frustrations that get in the way of looking after patients based on administrative decisions that have nothing to do with healthcare. But I just want to deviate a little bit, because we've touched on the fact that we've got unemployed physicians, we've got operating rooms that sit empty. At my institution, UHN, between the various hospitals, we have a massive number of operating rooms, something like 40 operating rooms. And we run them from 8 until 3:30 or maybe 5 o'clock in some instances. We run 1 or 2 emergency ORs on the weekend. And yet we've got the staff to do it. We've got the operating rooms to do it. We've got the anesthetists. And it just boggles my mind as to why Canada, why Ontario in particular has not entered into the medical tourism business. We have such a huge amount of unused capacity. And if you look at medical tourism as a business in other countries, Canada would fit very, very well. If you're in the Middle East or you're in Asia and you're thinking about going to the Mayo Clinic or the Cleveland Clinic, or you could come to Toronto, where are you going to go these days, particularly given the political climate? Canada is viewed so favorably on the international stage as far as its medical system and the quality of its physicians. So reputationally, we have a huge advantage over the US. And the argument that gets put out there, like almost anything that hits the public airways around healthcare, immediately gets shot down with sound bites of, well, we can't do that. Waiting times are going to be longer. It's not fair, this queue jumping. That's ridiculous. This money that we could generate can be used to generate profits that go right back into our healthcare system and start to fund it so that we can shorten our waiting time, so that we can utilize this infrastructure that we've built and we barely use, going back to the car production line. And it is immensely frustrating that we have not taken advantage of, I think, very distinct advantages that we have culturally as to how Canada is viewed. And I think if we started to really get our act together and just rationally shoot down these arguments that this will be unfair to the Canadian population, we have to get more money into the healthcare system. And we've got to find innovative ways of doing it and not taking advantage of medical tourism. We don't need to build new hospitals. We don't need to build new operating rooms. All we have to do is utilize this capacity that's sitting there unused. And we certainly can be smart enough to make sure that the revenues that are generated then go back into the healthcare system in an appropriate fashion to benefit all Ontarians, all Canadians.
Yeah, I was just in an OR where 50% of the ORs were empty, lights turned off. Nothing happening. It's real. Like, we have so much capacity. I just wanted to voice my strong support for all those comments.
Michael, anything to add?
Yes, thank you, Jeff. I'd like to speak to that very point. And as Wayne knows, the University Health Network in Toronto was involved in orthopedics and in cancer care in North Africa and the Middle East for a period of time. And we invested a fair amount in Kuwait and Qatar and Libya. And we brought some patients to Canada for surgery. The problems that we ran into in doing this were in part unexpected, a bit like vaccination rates dealing with the pandemic. Who would have thought that, you know, we'd have a vaccine, but people didn't want it? Well, this was the same thing, that we found our nursing staff and others, and some physicians as well, felt that this was competing for Canadian healthcare, where in fact it was revenue generating. And for every case we did, it allowed us to do another case for a Canadian. And we did these on weekends. We offered extra pay to people to volunteer to work. And yet there was a lot of pushback from the employees in general. So I think it really is a deeper problem. I agree entirely with what you said, Wayne, about our opportunities here. But 2 years ago, I was the physician advisor for the group. In fact, we closed down this operation completely. And, you know, it was a vice presidential decision. All of a sudden, we weren't in business anymore, sadly. And I don't quite understand it, frankly, but there we are.
I think this is a good way to end the webinar. We've got a realistic position from you that the money simply isn't there. We're going to have to generate some more money, but we've got to use it much more efficiently with different systems for long-term care, with more prevention, with use of more ambulatory surgical centers, more efficient use of our capital, more investment in equipment to make ourselves more efficient and get people back to work and stop the suffering. I want to thank everyone on the panel for being so generous with their contributions. We've got many more questions I'd like to cover, but thank you all, and thank you everyone for joining us. I hope you found it interesting and useful, and we would certainly welcome feedback. I'm sure the way of getting feedback to us will be advertised well. So let's all say goodbye. Thank you, and take care, and be careful. Stay well.
Thank you, Jeff.
Bye.
Thank you.
Thank you. Bye.